Good evening, Kanya.
Good evening, sir.
Good evening.
Sir, you can check your slide share.
Okay. I'll check it.
Sir, you have added Rekha ma'am slides, na?
No, ma'am.
No? She said to add.
Array, 38 slides were there.
Oh my God. फिर तो नहीं कर सकते.
So I wrote back to her,
हाँ.
too many slides.
Yeah, per question it will be 1 to 2 minutes only.
Was not really. Is it visible, ma'am?
Yes, sir, it is visible, sir.
I'll make it full screen. Now it is full screen.
Yeah, full screen.
Okay. So I'll stop sharing and then share. when-
Yes, sir, you can again then rescreen.
Because 38 slides means.
No, yes, you
would have
cannot have 38 slides. No way. Other people also have to speak.
Yes. That's why. Good evening, Dr. Ramakrishna, Dr. Naresh. Sudhir Mishra here.
Very good evening, sir.
All well?
Yes, sir.
Okay. Ramakrishna, sir, good evening. Ramakrishna, sir, am I audible?
Good evening, all. Dr. Naresh, Ramakrishna sir. Looks like
Rekha
Dr.
ma'am, good
Ramakrishna's
evening.
audio is not on. Audio, video, nothing is on. Good evening, Rekha ma'am.
Dr. Aarti, good evening.
Good evening, sir.
How are you?
Fine, fine. It's very well done session. I was just going through it.
Thank you. Good evening, Dr. Jai. Welcome.
Good evening, sir. How are you, sir?
Ramkrishna sir is angry. Not responding at all. Naresh, sir. Ramkrishna sir, am I audible?
Good evening, everyone.
Good evening, sir.
Good evening, Tiwari sir.
Good evening, sir. Good evening.
Good evening, all.
Good evening, all. Good evening, all, ma'am.
Ramkrishna sir, you are not audible.
Hello.
Unmute yourself. Although it does not know that you are mute. Yes, sir, good evening.
I think, sir, all have joined except Dr. Jugesh. Should I give her a call?
Dr. Jikesh.
Except Dr. Jugesh, all have joined. All panelists
Yes,
have
ma'am.
joined.
Yes, ma'am.
Ramkrishna sir.
Yes, sir.
Okay. Audible.
A message I sent you. You are talking about it, isn't it?
It's quite simple. I don't know.
No, you have seen my
You can
message.
do something about it.
Regarding the message I sent you, right?
Yeah.
Ah, right. Okay. Thanks.
Good evening, sir. Good evening, all.
Sir, good evening. Good evening.
Good evening,
Good evening,
Rekha
madam.
madam.
Good evening, ma'am.
Welcome, Dr. Keshavu.
Sir, good evening, sir. Good evening, sir.
Good evening.
Good evening, sir. Good evening.
Good evening, Rekha madam. Good evening.
Good evening, sir. Good evening.
Satish ji, good evening.
Good evening,
Good
Dr.
evening.
Keshavulu.
Good evening, Dr.
Today you
Sir,
are
good evening,
double
sir. Good
duty.
evening, sir.
Dr. Keshavulu,
Sir, good evening.
your duty has double today. Good morning and good evening both.
That Sudhir, any inputs for us you would like to suggest before we go on air?
No, sir. Just we have to take it as the way it progresses and keep talking.
I think your voice is
Yes, ma'am.
breaking.
Namaskar.
It is not problem from my side. Am I clearly audible? Dr. Keshav?
Yeah,
Dr. Mishra, sir, voice I think is breaking.
Yes, that's why I'm wondering.
Yeah.
Before commenting on others, I have to introspect myself. That's why I'm asking.
I think
Because
we
I am
should
not,
keep our,
my voice is
Sir.
not proper. Right.
except, sir, we should keep our videos off. We'll have a better transmission.
Madam, good evening, Kanya madam. Good evening.
Good evening, sir.
good
Where
evening,
are
sir.
you? Where are you in the dark US?
No, because it's evening, that's why he's maintaining the
Okay.
backdrop for it.
Yes, ma'am. Namaskar.
Good evening, Dr. Jugesh.
Madam,
I
unmute,
think.
unmute.
Yeah. Hello, everyone. Good evening.
Good evening, ma'am.
Good evening,
Yogesh,
ma'am.
Good evening.
Once it starts, please keep your videos off because it will give a better transmission then.
No, if there is any problem.
All
I mean,
audios and
Yeah.
videos, except those who are speaking, you can keep your audios and videos off.
no, for those who have some audibility problem, right? Speaking.
कन्या मैडम स्टार्ट कर दीजिए 7
Sir,
o'clock.
1859 hai, sir.
Okay.
Few seconds more. Oh, it is just 7 now in the iPhone. Okay, sir. So good evening to all, and I welcome for today's webinar on obesity, and we have named it as an emerging epidemic, which is really true. So I invite Dr. Tiwari, chairperson of the IOICF chapter, Dr. Rajinder Gulati, I am not sure whether he has joined or not, chairperson of Hambai, Dr. Aarti Kinikar madam, she is the secretary of Hambai, and the moderator, Dr. Sudhir Mishra. I also invite the eminent panelists who are going to join us today to give their very important outputs and inputs regarding how to detect, how to prevent, what are all morbidities associated with obesity. So it will definitely improve the knowledge of the practicing pediatricians, whoever is logging in for today's webinar. Dr. Mishra sir is the moderator for today's webinar, and he is the consultant pediatrician in Jamshedpur. He is ex-consultant and HOD in Tata Main Hospital and Manipal Tata Medical College in Jamshedpur. He was also vice president of CIAP East Zone in 2022. He is very actively actually associated with IOICF chapter from its inceptions. So first may I invite Dr. Tiwari sir to give the introductory comments.
Thank you all. On behalf of IYCF chapter of IIP, I invite all the panelists and all the delegates for this webinar on a very important topic, that is obesity. Though the name given for the topic is the emerging epidemic, but I think it will be something like pandemic, not an epidemic. And till now, for last 1.5 to 2 years, we were discussing about the maternal and child nutrition and topics related to that, that is undernutrition and human milk banking. So we thought that this is high time that we should go to the other spectrum of nutrition, and that is the overnutrition and obesity. So hence we have finalized this topic for today's webinar, which will be conducted by one of our senior most members, Dr. Sudhir Mishra. And of course, this time we have tried to involve the newer faculties, and the remaining 3 or 4 webinars in the coming month, that is October, November, December, also will try to have the next generation faculty, so that our second line is also in order, because it is important to give opportunities to the newer and newer faculties. So I welcome all the attendees again, and I hand over the mic for the further proceedings.
Thank you, sir. May I invite now Dr. Rajinder Gulati to say a few words? Gulati, sir.
Good evening, all of you. As Dr. Tiwari has said, that is not a disease which is to be taken very lightly. And it is one such disease which I am sure we all agree with it, that it is preventable. And the initial stage of obesity, which starts from the newborn period, I can say, goes into the adolescence. No doubt the number of adolescents being very huge and vast. They are almost 10 times the number of the obese children 0 to 5 years. So we need to prevent it, because in some countries, obesity is causing more deaths than undernutrition. So we need to take care of that. And with that motive in mind, I'm sure the panelists will do justice to today's webinar. All the best to all of you.
Thank you, sir. And sir, I would just like to add that it is not from the birth only. It starts from the in utero, its preparation for the metabolic syndrome later on in life. And lot of maternal factors, especially maternal obesity, maternal dietary habits, all this affect the later on the child's obesity. So we need to sort of prevent from in utero state onwards. So with this, I would like to hand over to Dr. Sudhir Mishra sir to introduce the panelists and to start the panel discussion.
Thank you, Kanya ma'am. Right at the outset, on behalf of I would like to thank
Sir,
Sir, your voice is breaking.
Dr. Kanya
No,
Sir,
you
your
may
voice is
switch off the camera.
for
All
giving us
please switch off. All to switch off their cameras and unmute only when you are speaking.
Okay, thank you, ma'am. So, right, good evening, everybody. And right at the outset, I would like to thank the Iap Iycf Chapter, especially the.
Sir, it is still not very clear, sir. Maybe you can come close to the mic, sir. Speakers. Sir, come close to the speakers.
Okay, ma'am. Am I
Yes, now it
audible,
is
ma'am?
better. Yes, sir, it is better now.
Okay. So, right at the outset, I would
No, sir, I think
So we can't hear you.
still it's not.
Sir, can you try switching off your video and see if the voice is clear?
Sure.
Yeah.
Am I audible?
Yes, now quite clear.
Quite clear. Thank you.
Yes, sir. Yeah.
So, good evening, everybody. On behalf of myself and my co-panelists, I would like to thank the Iap Iycf Chapter, especially the President and Secretary, Dr. Tiwari and Dr. Upadhyay, Dr. Gulati, and Dr. Aarti, for giving us this opportunity to really conduct this webinar. I have 5 experts to share their views, and I'll introduce them in The alphabetical order. Why is it not moving? So, first panelist is Dr. Jaivinder Yadav. He is Associate Professor of Pediatric Endocrinology in the Department of Pediatrics at IIT Chandigarh. Has 7 years of experience in pediatric endocrinology and has lots of papers and chapters in the book. As endocrinologist, obviously he has interest in the growth and the disorders of sex development and pregnancy. My next panelist is Professor Yogesh Chatwal, Professor and Head of Pediatrics at Government Medical College, Karnal, Savla Medical College. He has many publications and textbook chapters to her credit. She has conducted research projects and has been a speaker at national and conferences. She is especially interested in adolescent and non-communicable diseases. And of course, as professor, to have a keen interest. My third panelist is Dr. Naresh Sonkavade. I hope I am pronouncing it right. He is an assistant professor in the Department of Pediatrics at BJ Medical College and General Hospital, Pune, a prestigious hospital, and has about 7 years of experience. He is a trainer in National Life Emergency Support and also a IAP-BLS trainer and has lots of publications credit. Dr. Ramakrishna Paramhansa is a well-known person in the field of Indian Academy of Pediatrics. He has been guest speaker at many international conferences and of course national conferences. He was awarded IMA National Conference Vision. Has been a coordinator for IAP postgraduate quiz and editor also. He has publications to his credit and was a gold medalist. Last but not the least is the Dr. Rekha Harish, an FIA was a professor at Jammu Kashmir Medical College and then at IIM Delhi. Important thing to tell about is has been convener of the task force for prevention of obesity. One of the persons started working on pediatric obesity earliest. In addition, he has received a lot of awards, Beti Bachao, Beti Padhao, from the Rotary Club. He is an expert on the working on the junk in and around a national convener of IAP task force for prevention of childhood. He has done a lot of work on obesity and he is actually in the this becomes the question part. And I start with basic beginning. What we do is can really recognize
Because whom he is
in our
addressing.
clinics. Pardon me?
Sir, you are not audible, sir, at all.
Not audible at all.
Now, sir, speak loudly. Now it was audible, but earlier, sir, nothing was audible.
Okay.
Yes, sir, this word was audible. You are okay.
Okay.
So, yeah.
So even while walking, we recognize obese individuals. Ma'am, Rekha ma'am, is it recognize or we something else to recognize obesity early? Rekha ma'am.
Hello.
Yes,
I couldn't listen, sir. Hello,
ma'am.
am I audible?
You are audible, ma'am.
Thank you, sir.
Yes,
First of
sir,
all-
speak loudly. Sir, speak loudly. Whenever you are speaking loudly, it is audible. Otherwise,
Okay.
it was not. Yes.
At the outset, I thank the seniors of IYCF chapter for inviting me to join this prestigious webinar. And thank you, Dr. Mishra ji, for the kind introduction. So, as you are asking that while walking in the street, we recognize obese individual, is this the only way in our clinics, or we need to do something else? So the way the obesity is rising in all age groups, across all the regions, across all the borders and throughout the globe, and not even sparing the small babies less than 1 year also, visual recognition of obesity is never the desired way. We need to recognize obesity as early as possible and as clearly as possible, so that we take the effective preventive measures or management measures as soon as possible. And to recognize all these features, we need to know the anthropometry of the patient. The weight, height, BMI, and all of us know the formula for BMI also. Though BMI is not the exact way of assessing the adiposity in the body, it still remains the best surrogate measure of the body fat, because it measures the things so easily. The weight and height is to be taken clearly and precisely. It is inexpensive, it is non-invasive, and it's a surrogate measure of body fat. It correlates more to the direct measures of the body fat, such as underwater weighing and DEXA also. And high BMI has been can predict future morbidity and even death. So with increased availability and worldwide of the published population data, which is based on BMI, it allows us to make clear comparisons and manage and observe the trajectories. Although other measures of measuring the adiposity may be there, they are better, but still they cannot replace the inexpensive and the most easily done BMI. Though the drawback will remains that it does not measure the body fat exactly, and especially in athlete children, the muscle mass, the increased lean muscle mass may increase the BMI and give a false impression of obesity. So we need to do the BMI, check it according to the age, the gender, according to the pubertal age, whether the child is athletic or not, and interpret it accordingly. For children more than 5 years, we have the BMI charts made by the IAP, which were released in 2015. Subsequently, the extended BMI charts have also been released. The international charts of BMI, which were released by WHO on Z scoring and CDC, they are not applicable to the Asian population, because all of us are aware of the YY hypothesis and the Yudkin hypothesis, to be very precise, where they found that the body fat composition at the same BMI or a normal person also is much more in the Asian population as compared to the Western population. So it increases the cardiometabolic risk. Therefore, for the Asian population, on the basis of the IOTF recommendations and later on WHO also, the lower cutoffs for diagnosing obesity and overweight have been found. And similarly, IAP has adopted those cutoffs, that 23 adult equivalent be taken as a measure of cutoff for overweight, and 27 for obesity, and defined obesity from 5 to 18 years. It has further defined class 2 and class 3 of obesity, and 120% to 140% of the adult equivalent, and 140% or more for the 27 adult equivalent for class 2. For less than 5 years, we take the weight for length or height accordingly, and more than 2 standard deviations and less than 3 standard deviation remains overweight, and more than 3 standard deviation obese. Now this BMI should be done in all children when they come for all vaccination visits, and then at least every 6 monthly between 1 to 5 years, and yearly between from 5 years onwards.
Ma'am, thank you. We will talk about it little later in the course of the panel discussion. Thank you so much.
Thank you, sir.
My next question is to Dr. Yogesh Chatwal. Ma'am, we often hear the term overweight and obesity. Are they same or some different?
Am I audible to everybody?
Yes, ma'am, you are.
Okay. Most of the question has already been actually answered by Dr. Rekha. I would just reiterate that they are not same. They are overweight and obesity are different. And we do need to differentiate, especially for children also, even for adults, between overweight and obesity. And as the current guidelines are there, that for overweight, for children between 5 to 18 years of age, using the IAP 2015 growth charts, we have BMI more than 23 kilogram per meter square adult equivalent. That is what is taken as the cutoff for overweight. And for obesity, it is 27 adult equivalent. Also for children less than 5 years of age, Dr. Rekha has already said that we take weight for height on WHO graphs. It is not the 2015 growth charts. And for that, the plus 2 standard deviation is for overweight, and more than 3 standard deviation is for obesity for less than 5 years of age. So it is important that we do take, even for younger age groups, the cutoffs into consideration when we are doing their weights and heights and BMIs. And the risk for overweight may not be the same as for obesity, but it definitely needs attention. So they are not the same, but they both need attention. Thank you.
Thank you, ma'am. Basically, the overweight children are at the risk of becoming obese.
Yes.
That's the message. Therefore, overweight children need to be looked at the obesity. Dr. Param, I have seen many people otherwise look quite lean but have a very prominent belly. So, do we call them or consider them obese, or we don't consider them as obese?
Thank you. And belly being prominent and having big belly is a common scenario we see in Asians, more so in Indians, more so in South Indians. Compared to the being stocky appearance, uniform, having prominent belly is more worrisome. If a person is stocky, uniform, it is less problematic compared to the person who is having prominent belly. The reasons are, the fat deposition is very bad when it occurs subcutaneously. But it is still worse when the deposition occurs subcutaneously as well as in around the viscera. That makes the person or a child to prone many comorbidities and complications. Why? Because compared to the fat anywhere else, the fat that is deposited subcutaneously over the belly has more, it's a more causative for inflammation. That inflammation is much more because of production of a kind of protein from the fat that is deposited around the viscera, that is visceral fat, especially around liver, intestines and pancreas, put the child to more inflammation, which has deleterious effects over the various systems, resulting in metabolic syndromes and many complications. So, to sum up, the visceral fat is worse. Deposition of fat subcutaneously around the abdomen is bad.
Thank you, sir. So we need to measure the waist circumference for actually diagnosing the obesity?
Yes, sir. So the BMI, even though it's very easy and it has widespread usage, there are some caveats when you are assessing BMI, because it doesn't necessarily give an assessment of fat in the body, even the muscle mass, in the bone weight, all these things give some false reflections in assessing the BMI. So we have to be more objective in assessing the most important factor, that is the body fat content in the body. Further, you can measure the waist circumference. Waist circumference you do at the level of umbilicus. Why waist circumference? It is the area where the more fat is deposited, and that is the area where you will have some indirect reflection of the amount of the visceral fat in the body. So waist circumference is better, or a parameter that is to be considered along with BMI, and we may have the ratio of waist circumference and hip area, the measurement, the circumference around the hips, that gives a better idea about it. Even though it may not be much different from the waist circumference, but we are expected to take the hip ratio, waist hip ratio, because it tells about the fat content deposit, area of deposition. The reason is there are two types of shapes phenotypically. One is apple shape, that is more fat is deposited around the belly, and that is commonly seen in males. In females, it is pear-shaped phenotype. That means more fat is deposited around the hips and thighs. Compared to the apple type of phenotype, pear type of phenotype is relatively better. It is not that bad. The reason being what I was telling you, it is the visceral fat that is the biggest culprit, and that way females are more blessed to have the pear-shaped phenotype. That's why they are blessed with longer life, because they are not much exposed to the deleterious effects of the visceral fat. Right.
Thank you, sir. So we do need to measure definitely the waist and if possible the waist hip ratio, although they give almost result in most cases.
Right.
Dr. Naresh, the data from different studies show that there is a rising trend. So there is different methodology used. What is your personal experience?
Yes, thank you so much, sir. Am I audible to everyone?
Yes.
Yes, sir. As likely said, the obesity is becoming like an epidemic, and the rising trend of a prevalence is definitely seen in during the last 5 years. If you see the data from 1975 till 2016, the global age standardized prevalence of obesity in children and adolescents, which was aged between 5 to 19 years, has increased almost from 0.7 to 5.6 in girls and 0.9% to 7.8% for boys. Okay, so we can see that the trend has definitely increased, and surprisingly, in a high-income countries, this has plateaued since last 10 years around. But in low or medium-income countries like India, it is still continuing and in a rising trend of overweight and obesity both. When I was going through a few literatures, the meta-analysis done by Sakshi et al. Recently published in August 23, the last 20 years experience, the 21 studies from 2003 to 2023, done over 1.8 lakh children. The pooled prevalence they have found is about obesity of around 8.4% in a children and overweight about 12.4%. Okay, and in that same study, it has been seen that male are more commonly affected than the female. The private school children are more affected than the government school children. And as we know, the working mother, the children of a working mother are more affected than the non-working mother. These were the observations by that meta-analysis, what I have gone through. According to World Obesity Federation data, if you see the children and overall countries data, around 200 countries data over there. So the maximum obesity prevalence among the children, it's seen in Cook Island country, which has a 33.5%, and the minimum lowest is a 0.51% of Uganda. And we should be little happy about this is that India is 162 rank among the 200 with a 2.4% of overall obesity in prevalence in a children. But still, definitely this is an epidemic and rising trend, and it is a preventable. So to conclude, this is definitely 5 to 19 years, that is a childhood as well as the adolescent, considering this group. The obesity is ranging from different methodologically, different study wise. It is from the 1.5% to 12 to 14% it is, and the overweight is around 3% to around 20%. Thank you, sir.
Thank you, Dr. Naresh.
Dr.
Give me the
Sudhir,
comment.
a small part to add, a small sentence. See, these trends have become worse from 2020 with the onset of COVID. Many children were staying in the house in 2020 and 2021. So the incidence of overweight and obesity has risen quite high. And the studies show the lesser incidence, surprisingly, but in practice, we are seeing more and more overweight and obese children. That means the methodology is to be probably modified. Thank you.
Yeah, very true, sir.
Thank you, sir.
Thank
So
you,
you made a comment about working women and homemakers, the incidence being higher in working women. Do you find any specific reason for this, or it's just related to the sort of prosperity of working women?
sir. I can't hear exactly. The voice was breaking. Sorry.
No problem, I got it.
Dr. Naresh, you made a comment that it is higher in children with working women compared to those who are homemaking.
Yeah, because the working mothers are during the daytime when the child is with the child is at home, and it should be taken care. The nutrition part, the screen time, the physical activity part. These are all the responsibilities of the parents. If there are working mothers, then definitely some point of time, this all three factors are going to be suppressed indirectly, or we can say the subconsciously. So probably that was the observation during that study in a meta-analysis, that working mothers had more obese children than the non-working mother.
Right. Thank you, Dr. Naresh.
Yes, sir.
Dr. Jaivinder, many researchers think that there is urgency, although the incidence is somewhere around 1%, 2%. This needs to be addressed. Do you agree? And if you do so, why it is?
So thank you, sir, for the question, and thank you, IYCF, for giving me the opportunity to speak in this forum. So yes, sir, it's a great need to start addressing this problem, as it has been highlighted by the previous speakers and our seniors, that the obesity starts from in utero, and the prevalence is increasing in the childhood age. So we have to intervene early, because there are many studies in the Western world, and now coming from the Indian as well, that the obesity tracks from the childhood age to the adolescents and the adults. So it depends upon the severity of obesity prevalence in the parents, and the age of onset of obesity. So obesity in adolescents, there are very high chances, 80 to 90% chances that obesity will track into the adult age, and it will be associated with increased morbidity and mortality in the adults. So as all of us know, that obesity is associated with number of health impacts. So it is associated with the comorbidities. It can affect every system of body, starting from the brain to joints. So it's associated with increased cardiovascular morbidities. Hypertension is one of the common associations. The cardiovascular risk, increased risk for atherosclerosis, which may not manifest during the childhood age, but they will have the consequences in the adult age, and there is high mortality associated with the obesity. And up to 9 to 25% of the adolescents and children may have type 2 diabetes, and up to 50% of the children will have lipid abnormality. So all these factors, when they combine together, they increase risk of increased morbidity and mortality in adults. So there is a dire need that we have to go for the preventive steps early in the life, so that because the lifestyle of the children are set during this age, and it tend to persist during the adolescence and adult age. So this is the data which shows the comparison between 1995 and 2015. We can see the spikes that obesity associated adjusted life years are lost as the morbidity is increasing. And not only the obesity, overweight also leads to a number of these comorbidities and consume a lot of life years from the life of the overweight and obese obese individuals. So there's a dire need that we should be addressing this problem early in the life. So this is showing the mortality associated with the overweight and obesity, and we can see the clear spike over the span of around 20 years. So obesity is a pandemic and should be addressed from early on in the life.
So thank you, Dr. Javindra. Basically, the graphs, although you may not be able to size data, they very historically show that deaths associated with are increasing so much.
Yes, a point to add is, it is the first 1,000 golden days that are to be focused, not only for undernutrition, it is for overweight also. It should start right from the conception to take care of, to prevent IUGR initially, to have, prevent endocrine abnormalities, later on life, top feeds and appropriate complementary feeds. It should start right from the conception. Thank you.
Right. Thank you, sir. Dr. Naresh, do you consider it a disease?
Yes, sir, definitely.
Or it's just a normal variation of physical?
No, sir, definitely it is a disease, because if we consider a normal variation in the physical format, it should match into the age appropriate increase in the weight and other anthropometric parameters. But if it is inappropriate variation in these nomograms beyond certain limits, which can have short-term as well as the long-term effects or the complications and comorbidities, then definitely it should be considered as a disease. That's why even the ICD-10 codes obesity and overweight both have a disease coding, sir. Yep, thank you, sir.
Right. So till ICD-9, it was not there as ICD code, but ICD-10 has included disease. That's the message we wanted to convey. Jugesh, ma'am, although some morbidities have been explained, can you elaborate more on comorbidity related to health and disease?
Yeah. Okay. Am I audible?
Yes, ma'am.
Okay. So the comorbidities that can be there with obesity, I think some of them already have been elaborated upon. So actually the whole of the body from top to bottom can be involved. So there can be psychological or psychosocial problems because of their body image issues, or even otherwise neurological problems. They can be raised intracranial pressure, pseudotumor cerebri. And then going on to all the organ systems, practically all the organ systems can be involved: the respiratory system, the cardiovascular system, the gastrointestinal system, kidneys, musculoskeletal, endocrine, all these systems can be involved. Some of these are common, some may not be so common in all the obese children. The severity of the obesity may also have something to do with some of the comorbidities. So the message here is that once you have a child who has been diagnosed to have the disease of obesity, he must be screened for these issues because we do not know what all may be affected. Some of them need screening at the clinical level. Some of them may need screening at the biochemical level. So the ones which definitely need to be screened are the lipid abnormalities, or dyslipidemia needs to be screened in practically all obese children. And in overweight children with certain risk factors, hypertension would need clinical screening, and diabetes mellitus or a pre-diabetic state as well need to be screened, especially if there are risk factors in the family history or other stuff. And so these would need definite screening for liver problems, especially the MASLD or NAFLD, whatever we are calling it. also would need screening if the patient is having any ultrasound evidence, or if there is elevated liver enzymes, then definitely we need to keep them under watch for further development of fatty infiltration in the liver. So some of these are common. One of the things which does not get fully highlighted in this is because that will mainly be happening in girls, is the polycystic ovarian syndrome, which is fairly common association with the obesity. So the girls who have any menstrual problem, amenorrhea or menstrual irregularity, must be also screened for PCODs, because that can be a significant cause of morbidity in those children.
Right. Thank you.
These are the things we need to screen for. Thank you.
Right, ma'am. Thank you. Rekha, ma'am, we have been taught many syndromes that are associated with. Now, do we all, or we, or there are certain indicators, clinical?
Sudhir sir, you are not audible, sir.
Sir, your voice is breaking.
Rekha, ma'am,
And so,
Rekha,
so
ma'am,
just to align more, that we all have seen the increased morbidity and mortality in even the communicable diseases due to this non-communicable disease, obesity. The COVID and we all has shown us the importance of preventing obesity and we were all scared of the increased morbidity and mortality due to obesity itself. And as you rightly said, obesity has been classified classically into two types. One is the exogenous or the primary, or to be more precise, it is more of the lifestyle causing the unhealthy lifestyle causing the obesity. And the other group comprises of the secondary or the endogenous causes. And exogenous, it comprises of majority of these cases above 90% of the childhood obesity. And secondary causes, they take a chunk of less than 10% of them. And out of which less than 1% of all these cases are endocrinal in etiology. The primary or the exogenous is primarily differentiated by having increased in weight as well as increase in height. So if we have a child whose weight is excessive, whose height age is more, this is very likely to be an exogenous variety of obesity and does not need much investigations. But on the other hand, if we have a child who's having excessive weight but is showing evidence of reduced or very poor linear growth, this is the child who requires investigations for not only endocrinal workup, but he may be having any syndromic manifestation in the form of short stature. So any dysmorphism, which is a pointer towards any syndrome, it should, the Lawrence Moon beetle, Bardet beetle syndrome, the hypoparathyroidism, etc. They are all having some stigmata which are visible. Then the associated features of growth or developmental delay. So if the growth or development, any of them is affected, we must investigate. If the child has any vision abnormalities, like we find in many syndromes, it is a reason to investigate. If there are too many behavioral problems, too many developmental issues, definitely investigations are required. Then infantile obesity, especially if it is a very rapid weight gain, especially in the first few years of life, it signifies a genetic reason for obesity and needs investigations. Then the presence of hyperphagia. Hyperphagia means that this child has excessive appetite and which is non-discriminatory. He doesn't discriminate what to eat. He is not choosing anything to eat, but he is going on eating whatever comes his way. Then hypogonadism also signifies the reason for investigating.
To add to what Professor Rekha Madam told, in case of primary obesity, we examine, we look for complications and manifestations. In case of secondary obesity, primarily we look for the cause. What caused this? Right. So the management depends on the manifestations as well as cause. Manifestations in case of primary and cause in case of secondary.
Yes,
Right.
rightly said, sir. It is the reason to differentiate between the exogenous and secondary, because the evaluation and the management both will differ.
Right, ma'am. Right. Well said.
Thank you, ma'am. Sir, slides have gone off. I'm trying to put them back. But meanwhile, can you tell us which are the two most common measurements that we need to take for these children and how to really record them and plot them? Dr. Ramakrishna.
Like any child, we first see the weight. That is weight for age. Weight for age is a common thing we screen for each and every child and see over months and years. And we plot it on the growth charts. That gives a wonderful information where there is faltering in the growth as far as weight is concerned. And height is the one which we assess in every visit periodically to know whether there is any faltering in the growth. That means in other way it is stunting is there. And more important than these two is the derived value, that is weight for length in the first 2 years or weight for height in the later years. If generally it reflects very the status of the child. If it is on lower side, it tells about the morbidity and mortality. If it is on higher side, it tells again about the morbidity primarily. So if it is on underside, we call it a wasted child. If it is on higher side, we call it as overweight or obese child, depending on it. And we rely on weight for height up till the age of 5 years. Some countries take it as 2 years, but we take it as for 5 years. That's why we have to have the derived value of weight for height up till the age of 5 years. And beyond 5 years, we go for the BMI. And these are the three important things we do for each and every child. When you come across a child with overweight, we go for, in addition to weight for height, and BMI, we'll go for waist circumference and hip circumference. We have the charts for waist circumference. We have the charts for waist circumference. Based on the
where
charts,
do we find these India-specific chart? And how
we
do
have
we
India
assess the
specific
weight?
charts that were given to us right from 2015, and they differ from each race. Why we are not adopting WHO charts is there is a lot of variation based on the ethnicity, race, and geographical parameters. And it differs whether the baby is breastfed or top-fed. So we are taking our country-specific charts for BMI, also for weight versus hip versus waist ratio. If the ratio of circumference of waist in relation to hip, if it is more than 0.5, it is very significant and it is reflective of disease. That is overweight and obesity.
Right, sir. So there are certain tables shown on this. Can you elaborate on how to read this table?
Right, so the table is too. I think you can make it full screen. Even the full screen is also not that clear. And these are the values that are given for age, right from 5 years, 5.5 years, 6 years, 6.5 years, and 7 years. And they depict what is the 3rd percentile, what is the 10th percentile, 25th percentile, 50th percentile. And up till 75th percentile, we take it as normal. And when it crosses 75th percentile, we take it as abnormal. And we call when the BMI is more than 23 as overweight, When it crosses 27, we call it as obesity. This differs from the international parameters and charts. This is country specific. And when the BMI is more than 120% and up to 140% of the 95th percentile, we take it as class 2 obesity. And when it is more than 140%, we call it as class 3 obesity. To make things simple, if it is less than 5 percentile, we call it as underweight. 5th to 84th percentile, we say take it as normal. 85th to 94th percentile, we take it overweight. And above 95%, we call it as obesity. When it is more than 120% of the 95th percentile, we call it as class 2 obesity. When it is more than 140% of the 95th percentile, we call it as class 3 obesity. Right.
Thank you, sir. So basically what Dr. Paramans told us is that you look at the age in the first column, find out the age of the child, and then find out what is the BMI reading of that child, and then look up and see where the child belongs to, whether he is in the normal range or he is in the abnormal range. Thank you, sir. Dr. Naresh, what is the importance of waist circumference?
Yes, sir. As Dr. Ramakrishna sir has pointed out, the basis behind taking the waist circumference, because conventionally we take a BMI to categorize the disease as obese or overweight, or the child or the adult is going to have obesity. Okay, but as this is the different waist circumference is usually a marker for abdominal obesity, or we can call it as a visceral obesity. And this abdominal obesity is more common in Asian countries, like even the India comes in Asia. Okay, so the few important role this waist circumference are having, like it predicts the cardiometabolic risk and mortality and morbidity because of cardiac diseases in adulthood. So it is a very important factor in a day-to-day OPDs. We should definitely measure it. The measuring methods are differently described by WHO, NIH, and even in Indian guidelines, we have a method and as well as the charts for it. The WHO guidelines says the measurement should be taken between the midpoint between the lower border of the rib cage and the iliac crest, whereas the NIH guidelines says the superior border of iliac crest. And the Indian guideline charts published in 2014 by Khadilkar et al. They say that it has iliac crest or umbilicus region it matches with it. So there are different charts also. So to summarize this, the waist circumference definitely is a modifiable risk factor, which indicates the cardiometabolic risk, morbidity and mortality, and it has got a significance in all the consensus of AHA and even International Atherosclerosis Society, as well as the cardiovascular societies. So it correlates with the cardiac and metabolic disorders.
Right. Thank you, Dr. Naresh. Yogesh ma'am, can you elaborate on what is metabolic syndrome and how should we, how frequently, Naresh, we should measure this?
Yeah, it definitely starts from an infancy or the first visit. And as previously the panelists have described, during each vaccination visit, we should record it. And after 5 years, because 5 years to 19 years, there are definitely charts available. So annually, it should be recorded and predicted. Any metabolic or cardiovascular disease prediction is there. And it should be a linear plotting should be there rather than a one time, so that we can compare whether it is a rising abdominal obesity or not. Thank you, sir.
Thank you, Dr. Naresh.
Yes.
What are the investigations that we certainly need to do in these children? This can be, Rekha ma'am, can you take this?
Hello.
Rekha ma'am, can you take this? What are the investigations that we should do and when we should do these investigations?
So can I highlight on this?
Hello, Rekha ma'am? Am I audible?
Yeah, you are audible. Should I put anybody else?
Yeah, Rekha madam is not available, so
Yes.
either Dr.
Okay.
Naresh or Dr.
Yes,
Chintan.
yes.
Continue.
May I take,
Go ahead.
sir? Dr.
Yes,
Naresh is talking.
please.
Yeah,
May I
yeah,
take, sir?
Dr. Naresh, please go ahead.
Thank you so much, sir. As we are saying that the obesity has many comorbidities and complications, there are two basic investigations required to rule out the etiology that Rekha madam has definitely described very nicely. And the second component is definitely complications, which can be missed in the exogenous or the primary obesity. Okay, and there should not be definitely a blanket investigation like a fasting or lipid profile. So there are a few specific recommendations by international societies. Like AHA says, around after 9 to 11 years, the dyslipidemia should be frequently done to see the lipid profile changes in the children. The ADA, Diabetic Society, says that the type 2 diabetes is a common in the children about 10 years of age. So the diabetes screening is recommended after 10 years by the ADA Society. In the 2017, the American Academy of Pediatric have highlighted that the child age, if it is more than 3 years, then the hypertension is definitely a risk factor or the complication which can be there in the obese children. So definitely we have a blood pressure monitoring. If we are not practicing it, then we should start doing the BMI, waist circumference, and the hypertension monitoring right from the 3 years of age according to the AAP, and definitely the Indian pediatrics will be coming with this probably the same guidelines. And the other complications are like obstructive sleep apnea or even the PCOS. If the history is suggestive or leading towards the investigations required, then definitely we should go ahead with the polysomnography for obstructive sleep apnea. And in a girls, the ultrasound of abdomen and the pelvis to detect the PCOS and even the other comorbidities of hypertension in the same. Thank you so much, sir.
Thank you,
To
Dinesh.
add a few
Can I
points,
just
to
add
add a
to
few
this?
points.
Yeah, okay.
Yes, ma'am.
Yeah.
See, the investigations are not the primary one. It is always
Ma'am,
evaluation
ma'am,
physically,
so-
and depending on the phenotype, you have to investigate. Suppose the child is having acanthosis nigricans, like you may go for diabetes workup. If you think there is a lot of fat deposition in abnormal places, you go for proximally for lipid profile assessment. When the child is having symptoms suggestive of hypertension, you may go for BP, and suggestive of hypothyroidism, you may go for thyroid profile. The
Right, sir.
ultrasound abdomen is the one which is very much required, not simply just for PCOS and hypertension. It has a lot of value to diagnose NAFLD or MAFLD. That is the one investigation which gives information about the occurrence of NAFLD, which is very common. It is found to be 30 to 40% of the children, obese children. So the ultrasound is necessary in all the obese children, which gives a lot of information about NAFLD. No other investigation will tell you about NAFLD. Thank you.
So, thank you, sir. Thank you, sir, for that addition. However, the consensus as of now is that we should not investigate these children as a blanket that everything has to be done in all children. There are some basic investigation, and then depending on the clinical requirement, the science, as Dr. Ramakrishna has really pointed out so nicely, based on them that we go with this thing. So, Jugesh ma'am, we have been talking of metabolic syndrome, and we heard of it in the adults, but is it prevalent in children also? And then how do we identify metabolic syndrome in children?
Okay. The metabolic syndrome, of course, it is well defined in adults, but it is known to occur in children, especially children who have a lot of central adiposity, and it definitely needs to be considered in children. There is no consensus definition for the metabolic syndrome in children as yet, but there's an overlap. So some things have been adapted from the adult definitions, and one of the definitions which is frequently used is the International Diabetes Federation definition, which has given us the waist circumference of 90th centile. But for India, since we are considering 70th percentile as the abnormal cutoff for the central obesity. So we would say that if children are of 10 to 16 years of age with central adiposity, which translates into a 70th percentile waist circumference, and along with that, if they have any of the following, that is dyslipidemia, basically triglycerides, which are equal to or more than 150 milligram per deciliter, or an HDL cholesterol, which is equal to or less than 40 milligram per deciliter, a fasting blood glucose, which is equal to or more than 100 milligram per deciliter, and a systolic BP more than 130, and a diastolic BP equal to more than 85. Or they should be 95th centile adjusted for age, height, and gender. That is for blood pressure. So it is important that when we have children coming to us with central obesity, that they are screened for these abnormalities. And so in those children, it would be necessary to do the lipid profile as well as do a fasting blood glucose, and sometimes if required, maybe an HB1AC as well. And definitely all children, obese children, that is all obese children and even overweight children, must have screening for blood pressure, because elevated blood pressure is frequently associated among these children. So these are important things. And if they are in a range of obesity in which we need to consider NAFLD, then and liver function test would also be an important investigation. Thank you.
Can I
Thank
add
you, ma'am.
one line?
Sure.
Sir, can I add one line?
Yes, ma'am.
Yeah. So while we are discussing this metabolic syndrome, I think the SGA children, as well as this very preterm survivors, they are also prone for this metabolic syndrome. And though many times they will be actually quite malnourished, but these babies are prone for metabolic syndrome. So these children also need a periodically screening for this, the lipid profiles. And in these cases, the HOMA IR is also very important. There are many studies, even these children, preterm and SGA from 6 months onwards, they show the increased HOMA IR. That means they have a tendency to have insulin resistance down the line. So I would say that this group also should be included in the screening for metabolic syndrome from very early in life.
Thank you, Dr. Kanya. So the concern of neonatologists about SGA babies is very, very genuine. Thank you so much.
And very preterm. And the very preterm survivors, even they are also equally prone.
Jogesh ma'am, just wanted to know, for everything we take 95th percentile or even 97th percentile as the cutoff. Why 70th percentile for this particular measurement?
Yeah, because that is the percentile which has been seen to have a higher rate of associated comorbidities. For that reason, that is taken as the cutoff.
Lower cutoff percentile.
Lower cutoff, yes.
And that is the reason the investigations which we said should be done in all children are these
Yes, exactly. Very well said. Yeah, thank you.
Thank you so much. So, Dr. Ramakrishna, do we need to really do only this much, or need to see different systems also and find out the abnormalities in different systems?
So the examination of a overweight or obese child should be a thorough general examination that gives lot of information. See, in the general examination, you may be seeing acanthosis and aggregans, you may be seeing fat deposition, isolated places, and you may see lipomastia, previously called as gynecomastia. So you look for all those manifestations. And coming to system-specific symptoms, we shall be a little more focused, because based on the symptoms, the comorbidity is connected. So whenever there is nervousness, school avoidance, and social inhibitions, and being faced with bullying and all, so that may lead. See, the bullying is a big problem for children who are obese by the peers. They will be bullied. So it may lead to depression, anxiety. And if the child is having a lot of fatigue out of proportional to his other parameters, physical parameters, and the muscle aches are there, you may consider vitamin D deficiency. Even though the child is overweight and obese, they are prone to have vitamin D deficiency. And as all of us know, the type 2 diabetes and hypertension are the biggest problems when the child has polyuria and fatigue and nocturia, consider whether the child is having type 2 diabetes. And the one which is generally missed, because it's a vague symptom of having facial numbness and headache, it may be actually a child with pseudotumor cerebri. And that unless we are focused, unless we think of it, we'll be never able to diagnose. And if there are, as I was telling you, acanthosis nigricans or skin tags which are of lipid, containing lipid, that is suggestive of insulin resistant. And obstructive sleep apnea is a big problem in children with obesity and overweight. And they have very subtle symptoms like daytime somnolence and snoring and sometimes apnea that may not be noticed always, and attention deficit. These are the things symptoms which are not very much focused by many a doctor, but still they are the one which require a lot of attention because these children are more prone to have OSA. And if the child has abdominal pain and indigestion, may be suggestive of giardia and gallbladder disease. And if they are having any orthopedic problems like knee pain or hip pain, think of whether the child is having slippery capital femoral epiphysis and osteoarthritis. If there is intowing and load bowing, it may be a case of Blount's disease. And not to miss hirsutism, acne, irregular menses, and overweight, and leading to obesity. The girl may be actually having polycystic ovarian disease. So these are the symptoms which we have to focus so that we will be knowing what is the actual comorbidity. Then we can evaluate the child in a focused manner without subjecting the child
Thank you,
to
sir. So
various
it's not about
investigations. Right.
Thank you, sir. So it's not about metabolic syndrome only. There are much more to obesity and comorbidities associated with it than the metabolic syndrome alone. So, sir, since you have elaborated it so nicely, can I ask you to continue and tell us what are the preventive strategy? Because prevention is so important. Cure is more difficult as usual.
Right, sir. The prevention shall start right from fetal life. That's what I was referring to. First 1,000 days are golden days in the nutrition of the baby. Let it be on the lower side or the higher side. Right? It should start from intrauterine life. The further we have to focus on the appropriate maternal nutrition and appropriate weight gain of the mother during the pregnancy. Then we have to prevent the preterm deliveries. We have to see that IUGR, the baby doesn't go into IUGR, because these are the risk factors for later obesity. Paradoxically, they may lead to obesity in the later life. And it is the top feeds, that is artificial feeds, that are the biggest culprit causing obesity, especially in the infancy, toddler period, and early childhood. To make the milk more tasty, most of the manufacturers add a lot of lactose. That leads to obesity, making the parents think that their child is very, very healthy, which is actually it is other way around. So we have to see that the child has only breastfeeding up till 2 years and beyond, and to strictly advise them not to go for 6 months top feeds. And we have to tell them it is not healthy weight gain, and it is going to lead to many complications. And complementary feeding is one which is either delayed or sometimes it is introduced very early. That is another culprit. And the way, what are the components of the complementary feed also, they may lead to obesity. And beyond the preschool age, it is the packed foods that are the biggest culprit. I don't say courtesy of the media, it is the curse of the media that results in the children opting for empty calories and the so-called packaged foods, which are not manufactured as per the norms in our country. We have to strongly discourage the junk food and sugar sweetened beverages and high sodium containing foods. High sodium is also one food that leads to overweight and obesity. And we have to maintain the growth charts right from the birth to up till adolescence to see the pattern of the growth, weight as well as height, BMI, so that whenever there is some faltering either this way or that way, we shall swing into action so that early prevention can help the child to become overweight or obese.
Thank you, sir. So the important message is that even during infancy, we are very used to looking at child not gaining weight, but we definitely need to plot it on the growth charts to see if the child is crossing 2 centile lines, and that would be considered excessive weight gain, and take care of it. So, Jugesh ma'am, what are the preventive strategies in children and adolescents? What do we encourage and what do we discourage? Jugesh ma'am?
Yeah, I have unmuted myself. Yeah, carrying on from infancy, we go into early childhood and later childhood as well as adolescence. So the importance of eating home-based food, that is whole grains, fruits, vegetables, all of this cannot be highlighted enough, because those are one of the most important things that are required for preventive strategies for obesity. So the common thing, dictum of 5 servings of fruits and vegetable per day, that definitely must be inculcated in the children right from the beginning, because if we don't start early, they will never get to that part. And then the 5 goes to 2 hours of the screen time. And so not more than 2 hours of the screen time should be there for older children. For less than 2 to 3 years, of course, it is 0 hour of screen time preferably. And 1 hour of physical activity. This is a very important thing, because physical activity has become kind of almost negligible in most urban areas, and especially in schools, because they do not have any games period or sports activity. Only children who are interested in sports may be doing, but most other children just sit and spend their time in schools and come back home and get busy with tuition work and homework. So physical activity has really been one of the things which has taken a big hit in the way our urban life has become. Living in small flats and societies, there is very often no place even for playing. So physical activity of 1 hour is a must, and on most days it should also be with vigorous kind of a physical activity. And then 0 is for not taking any of the sugar sweetened beverages. So that should be discouraged from all beginning to the right through the adolescence. So packaged snacks to be discouraged, all deep fried food items. The Indian samosas becoming a staple for children definitely need to be discouraged. Yeah, sugar sweetened beverages, which are very popular with children, all kinds of commercial drinks as well as juices. So very often mothers just give a fruity pack along with the lunch pack so that he can take it, that full of sugar. Junks, we all know, have to be definitely a no-no. And overly restrictive behavior. We will come back to this in a little while later, I think, when we are talking about motivational interviewing. But overly restrictive behavior also is not good, because you need to take the child into confidence and advise them accordingly as parents, becoming their friends, that this is not something which you should be doing. And screen time, as I have already mentioned, the current, after especially post-COVID, the screen time has definitely increased with online teaching and online homeworks being given to all children. So once the academic screen time is over, this should be followed by almost 0 screen time of any other kind. Because very often nowadays children are using phones and laptops for doing their homeworks. And that is taking toll on their eyes as well as on their weight. So after that thing is over, there should be no other screen time. So that should be discouraged definitely.
So basically, ma'am, you are saying that all the Khans and Kohlis, they have to be thrown out of the home. Thank you so much.
To add 2 more sentences.
Dr. Naresh, can you elaborate on the nutritional management of obesity?
Yes, sir. The nutrition as the prevention is definitely starts from the birth and even before the birth. But if we consider the obesity as now after the disease and the nutritional management part, the goal should be about the weight maintenance rather than the weight loss. The below 6 years, the weight loss is ideally not recommended. Only in the severe obesity cases, we consider the weight loss strategies as about 0.5 kg per month reduction from in the age group of 2 to 5, and around 1 kg per week for the older children or the adolescent. So the target reduction in the weight and height should be it should be plotted, and the calorie restriction is not usually recommended, as likely said previously said, below 6 years of age. We have the traffic light or the stoplight diet, which is there, which has a three signals like a green, yellow, and red. So the green can be taken or eaten frequently, and the yellow should be taken occasionally, and the red, which is to be avoided or rarely taken. So in the green categories, there are many low carbohydrate diet, more of fiber, and the fruits and vegetables should be included to manage the obesity. And definitely the junk foods, which is just now we have discussed that there are many companies with many advertise the junk foods has become now the everyday the starting as well as the day ending food for children. And even it is a sometimes considered as a positive reward system for a child. Okay, calm down, ye le lo kurkure. Okay, that should be discouraged. And there are even a micronutrient distribution management part wise, that having a low fat diet that is less than 30% or 33%. We can include the low carbohydrate diet and the protein around 15 to 20%. But if we overall consider, there are no fixed consensus overall for the age group. It depends on the family type, their cultural background, the age of a child, the categories of category of obesity. So it should be individual centered, or we can say the family centered. And all family members should acclimatize to that environment of a eating pattern and whatever the dietary advice we have given for we give for the obese children. Okay, thank you so much,
Thanks,
sir.
Naresh. And that's
Just
the
like to
very
add-
important message. It has
Yeah,
to be a family-centered diet.
Exactly. Yeah, that's what I just wanted to emphasize, that the family has to be going together on this diet
Right.
as well as physical activity. Thank you. Yeah.
Thank you, ma'am. Rekha,
Sir,
ma'am,
it is
managing-
sir 8:15. Sir, it is 8:15. So
Yes, ma'am, we are expediting.
Yeah.
Rekha, ma'am, infants, it's most difficult to manage because we have to cater to the linear growth, but we have to maintain the weight. How do we do that?
So at the outset, I would like to just highlight 2 or 3 points when we are talking about management of obesity, that this is one disease where prevention and management, both they are overlapping to a large extent. And secondly, when we are differentiating the management of any child in any age group as compared to the adults, our goal is not just weight loss. Our goal is change in behavior of the child, change in eating behaviors and the lifestyle behaviors, so that the effect is lasting lifelong. Because in adults, it may be true that you go for a crash dieting and reduce 5 kg, but that is not holding true for children. And since we are starting, it's as rightly pointed out by Dr. Kanya ma'am, that it is primordial prevention. So we are right now from maternal time, and then we are talking about the prevention of early or high catch-up growth also, keeping in view the Barker's hypothesis in mind. So whosoever child gains weight very rapidly during infancy is likely to develop metabolic syndromes and later on the complications. So these things have to be kept in mind. And secondly, when we are talking only for infants, suppose we are talking till for these children, we are encountering more of secondary obesity in these children. And once we are getting any genetic or any secondary syndromal cause for obesity, there the nutritional guidance will not matter much, because that will not be controllable. And it becomes a very frustrating experience for the caretakers also, until unless you have especially like you have a leptin replacement, recombinant leptin replacement therapy, where the things will work out well. Then the regarding the weight loss or the weight maintenance. So in childhood, one edge what the pediatricians have over the adult obesity management is that the phases in which the children are gaining rapidly their linear growth, or they are gaining height rapidly, their weight maintenance works like wonders. So if the child is like ushering into puberty, a spurt of puberty, and there you have an excessive weight, so just maintaining the same weight for 2 years and the child's BMI will come out to be normal because his height has increased. But that may similarly not be that effective for infants. And in infancy, as rightly already said by Dr. Ramakrishnan ji, that we start with at birth by starting with exclusive breastfeeding. And we know that that is the first step towards prevention of obesity immediately after birth. And I say that it is one intervention which prevents obesity in 2 generations, not only the baby, but also the mother. And it has a consistent risk reduction for later obesity to the tune of 12 to 22%. Later on, as already the highlighted by sir about the complementary feeding, I would not repeat the same, but yes, we need for whenever we are advising the healthy eating behaviors, we not only look into the quantity, we look into the quality, but also the eating behaviors. But eating behaviors, I mean that the parents or the family members are the role models. So the caregivers should be having a family meal time and giving age appropriate, locally available, seasonal fruits and vegetables being incorporated, and age appropriate consistency according to the IYCF standard, IYCF and IAB guidelines, and follow it right from 6 months of age along with the breastfeeding, which was already there in the initial 6 months. Then we must encourage autonomy or self-regulation of the eating behavior, because the child should be able to differentiate and learn to differentiate between hunger and fullness. And force feeding, like forcing the child with the feed unnecessarily, this much is left, you have to finish it, that should be strongly discouraged. Then watching TV or any screen while feeding is another reason which can lead to suppression of these satiety and hunger, satiety reflex, and lead to excessive feeding. So these things have to be controlled in the environment, and food should never ever be a part of reward or punishment, that if you have done this, so you'll get a candy, if you have done the homework good, or whatever the reason is, you get an ice cream. And this is common even in our families, where the parents are even doctors, and when they stay away for a long time, they bring in ice creams and chocolates. Then we must have some
time is short, so we need to restrict little bit. What I would like to ask, focus you is on which is more important, nutritional management or physical activity?
Sir, nutritional as well as physical activity, both the managements are important. We cannot skip the nutritional management, and we cannot skip the physical activity part also. And we must remember that physical activity is the only component in the energy expenditure arm. So we have to stress upon that, and there is no other way to utilize the excessive calories. So this physical activity needs to be incorporated right from infancy, right from the neonatal period, as because inactivity is one of the leading factors for not only obesity, but for all NCDs and even premature deaths. It shortens the lifespan. We have already seen it reduces the lifespan by 3 to 4 years. And globally, around 80% of the children, adolescent children, are physically inactive. So, and in India, the same figure is around 74%. So we need to incorporate physical activity in whatever possible way possible according to age, according to the preferences of the child, according to the socioeconomic status of the child, according to the available facilities for the child, according to the available space for the child. And roughly 17 years old child should accumulate at least 60 minutes of physical activity in a day. And it should comprise of some aerobic activities, which should be of moderate or vigorous intensity. So since the time is short, we'll not talk about the maths and details. It should be coupled with muscle strengthening activities, which should be incorporated at least 3 days in a week for 20 minutes stretch, and some bone strengthening activities 3 days in a week as a part of the aerobic activity. For the 1 year, 1 to 2 years, below 1 year, you should have encourage the lying prone or the tummy time. The activity part starts from that phase of life, and it should be incorporated, and the child should never be strapped or kept in still sitting position for more than 1 hour. That is very important. The screen should not be introduced to the child during infancy, because once they are glued to screen, they are likely to be sedentary for long times, and that habit is very difficult to manage.
We'll stop here this particular thing because of the time. Yogesh ma'am, can you highlight about the motivational interviewing that is coming up as a method for adolescents?
Thank you, Dr. Mishra. Yeah, motivational interviewing is a very important thing which we all as doctors need to, and pediatricians especially, need to become aware of, especially if we are dealing with adolescents, because this is a technique primarily for a behavior change. And when we are talking of obesity, behavior change is the major thing that we need. So in this, there is therapy as well as interviewing together. So we are giving them motivational interviewing by giving them, we ask them to have the doctors to have empathy and not sympathy. They should be non-judgmental instead of coming out, "Tum ye kya kar rahe ho, ye kaise kar rahe ho." So we empathize with the situation with which the child is there, and help the child understand the difference between what he's doing and what is the desired behavior. Once he sees that this is what he's doing and this is what his peer group is, or where his peer group is and where he is, then that realization, once it sinks in, then maybe he can start thinking of a change in the way he is doing things. And we do not try to resist, or we do not try to fight with what the child is saying. We can only ask him to look at the options and then see what he can accomplish. So offer him whatever is possible. Let him see what the differences are. Let him see how he wants to do it, and then support him in whatever he wants to do it. So the methods for providing motivational interviewing would be asking open-ended questions and let the adolescent speak, and provide affirmations for something which he is doing instead of negating the whole thing. Let him reflect on what is wrong with his behavior, and from there see if he can move on to change his behavior and feel efficacious enough to change something. So that is how motivational interviewing can happen, and it doesn't happen over one sitting. It takes a period of time. And here, since we are talking of behavioral change, it can never happen in a very short time. But the important thing is you roll with the child and you don't fight with the child. So that's the most important thing about motivational interviewing.
Thank you, ma'am. It's a big topic. Thank you for summarizing it so fast. We have already talked about the sleep hygiene and the screen time. So I will skip these slides and go directly to Dr. Jaivinder. Can you elaborate on role of pharmacotherapy?
Yeah, sir. The role of pharmacotherapy is very less in pediatric obesity. Most of the pediatric obesity is managed with lifestyle modification, as has been described before. So pharmacotherapy comes into play if you have a syndromic or monogenic obesity, or in cases of severe obesity associated with the comorbidities. And there are only handful of drugs which have been approved, and most of the drugs have been approved after the age of 12 years. So two most commonly used drugs are orlistat and liraglutide. So orlistat, the weight loss is around 1. The BMI reduction is around 1.1 to 1.5. So that's comparable with the lifestyle modification. And there are a lot of side effects associated with use of this drug. And the monthly cost comes out to be around 4,000 per month. And liraglutide is a newer GLP-1 analogs, and the weekly GLP-1 and semaglutide has been recently approved. So, but the cost of these drugs is prohibitive. It costs around 1,000 per month for use of these drugs, which is not affordable for many of the families.
So,
And for
Devinder, I would like to ask you, do you have
yes.
personal experience of using any of these two or both the drugs, and how frequently they are successful?
So we have used orlistat, liraglutide we have not used. So orlistat the patient used till 6 months to 1 year, but there is a lot of side effects like the flatulence and the oily stools, frequent passages. And the BMI reduction is only one of they lose around 3 to 5 kg of weight loss. So most of the patients are not compliant with the drug. So and metformin is the other drug which is used more frequently, but it is not approved for obesity. So if obesity is associated with insulin resistance, like there is pre-diabetes or diabetes, then you can use metformin in these patients.
Right.
And both
Thank you.
monogenic obesity specific like drugs like your leptin replacement and stimelanotide is a specific drug for MC4R mutations, so which are approved for the specific indications that
Right.
wrong
Thank you.
MC4R.
Thank you, Javinder. Any
Yes.
comments on surgery, its needs and indications?
Yes, so surgery also is in infancy stage for pediatric obesity, but now newer studies have been coming up and surgery is being utilized in class 2 and class 3 obesity indications where the options are limited and lifestyle modification doesn't help much. So in adolescents, people are doing surgery. There's a recent paper from the AIMS. They have done the bariatric surgeries and around 10 patients and so on. Reduction of BMI of up to the BMI reduced from 47 mean BMI to 35. But still, it's an indication when all our options have been exhausted and we have tried the lifestyle modification at its best, but still the things are not moving into the positive direction, then surgery can be one of the options. People have
Dr.
reported
Javinder.
surgery in early. Yes.
And with that, we come to the end. I would like to summarize that obesity is increasing. We need to focus on the proper optimal dietary management and the physical activity. We need to investigate these patients carefully, do detailed clinical examination as was elaborated by the experts, not to miss any of the complications, because presence of any of these complications, they actually promote the proper management of obesity. They convince the parents that they need to take it more seriously than merely our words. Thank you all the panelists for the excellent work that you have done. And I hand over to Dr. Kanya. If there are any questions, the experts will be happy to answer.
Sir, there was one question in
ma'am.
the chat box about what is adult equivalent of 27.
What is adult equivalent of 27? Rekha ma'am, can you take it?
Should I
This
answer?
was there in one
Should I-
slide. So.
Yes, yes. Rekha ma'am, can you take it? Anyone
Sir,
can
it
take
is-
that.
Yeah.
It is adult BMI of 27, which is taken as cutoff for obesity for Asian population and not taken by the Western this thing. And the adult equivalent of 27, when it is shown on the same centile as per the age, that is taken as the cutoff, as was shown in the charts. So that
Right,
is decides the cutoff for the particular child
So-
age group.
So we can understand it very simply that if this child is not put to any interventions, he is likely to become an adult with a BMI of 27 and also is likely to have the same type of complications. If we can understand it that way, will that be right?
Yes, yes.
Yeah.
Because most of the obesity which has occurred or begun less than 5 years of age is likely to persist lifelong.
Thank you, ma'am. Kanya ma'am, any other question?
No, not in the chat box, sir.
Kanya
Thank you.
ma'am,
So over to you.
Dr. Kanya ma'am, shall we
Yes,
have
sir.
one or two sentences from Dr. D.M. Gupta and Dr. Others who are doing good work in this?
Yes, sir, sure.
Right. Dr. D.M. Gupta and Professor Others.
डॉक्टर सुधीर,
Sir,
आपका ये स्क्रीन शेयरिंग बंद करने का ठीक है?
कर दिया, कर दिया, कर दिया.
Professor Others. Dr. D.M. Gupta. So they are not with us, right?
Okay. Sir, you can all switch on now your videos. I'll just take a photo. And is Dr. Tiwari is having any concluding remarks? Otherwise, we'll wrap it up.
No,
And
Dr.
I would-
Adarsh and Dr. Gupta are saying something.
But I don't know they are online or not. If they are online, yes, Dr. Adarsh.
Dr. Adarsh is there. I can see Dr. Gupta also.
Yeah. Dr. Others.
Till they join, Dr. Keshavulu, your comments.
So thank you very much, sir, for giving me the opportunity and a very good opportunity for me to participate. And as Professor Ramakrishna Paramahamsa sir and Rekha madam was telling, so we have to start working prevention of the obesity right from the time of birth by promoting optimal infant and young child feeding practices like early initiation of breastfeeding and the exclusive breastfeeding for 6 months and sticking to the homemade complementary food, keeping away from the high salty, high fatty, high sugary junk foods. So these go in a long way for preventing obesity and other non-communicable diseases. So it is excellent deliberation and all the panelists did very well. And thank you so much for giving me the opportunity, sir.
So, sir, so I would like to thank all the panelists.
Dr. D.M. Gupta.
He is there online, but
Dr. Adarsh. Okay, so I think we have also completed the time limit. It's already 8:34. So on behalf of IYCF chapter, I thank all the panelists who have participated very actively. And I thank the moderator, Dr. Sudhir Gupta, for taking up for this such a vast topic in a deputed amount of time and making it so simple and so short. So thank you again. I think in the remaining 2 or 3 webinars, we will have to cover the other remaining important topics like role of media and role of different stakeholders on all this. We will do that in the coming. And I think that today's topic was very important and very well dealt in short by all the panelists. Thank you.
I would like to do special thanks not only to our stalwarts like Dr. Rekha madam, Dr. Jugesh madam, Dr. Misra sir, Dr. Ramakrishna, but our young generations. I'm happy that the young generation joined. Dr. Naresh and Dr. Jaivinder, and we expect more and more young generation to participate in these webinars more actively. So I would like to thank you all again. And if anyone has
Dr.
any
Raghunath is there. He wants to say something. Dr. Raghunath.
Dr. Raghunath switched off his video and audio.
Hello.
If
It
anyone
was
has
a very
any
good
last-minute
discussion.
comment. If anyone
Thank you
has
very
any-
much for the very fantastic discussion on obesity. It was really enchanting. I thank you once again. It was really very nice. We enjoyed the Sunday evening. Thank you.
Okay, so thank you all again and have a good night.
Thank
And
you.
enjoy your rest
Thank
of
you.
the Saturday
Thanks.
evening.
So bye
Thank you.
everyone.
Bye.
Okay.
Thank you. Thank you.
Thank you.
Thank you, sir. Thank you. Thank you, everybody.
Thank you, everyone.
कन्या मैडम
Yes, sir.
दुबे सर से बात कर लेना आप for that
हाँ, sir.
CP.
I'll give him a call tomorrow. Sunday, I did not want to bother him.
Okay. And ब्रेस्ट फीडिंग गाइडलाइन में 3-4 दिन में भेजता हूँ, उसमें थोड़ा अपने को स्टैटिस्टिक्स डालना पड़ेगा. आई थिंक इट इज नॉट देयर.
ठीक है सर, आप मेरे को फोन कीजिए because this is online.
ओके.
Okay. Good night.
Good night to all. Right.